If you are pregnant or you've recently had a baby, this podcast is for you. I'm your host, Kath Baquie. I'm a physiotherapist working in women's health and mum of 3. Inside my online program, Fitness Mama, I help women feel confident and strong inside out as they navigate pregnancy, birth, and postnatal recovery. Each week, I bring you 2 episodes to support you on your motherhood journey, whether it's real and raw birth stories from fellow mums, expert interviews with trusted health professionals, or bite-sized Q&As where I answer your most common questions. It is possible to feel amazing in your body during this stage of life, and I want that for you. Come and say hi on Instagram at kathbaquie.physio, and let's dive into today's episode. Hello, welcome back to the Pregnancy, Birth and Recovery podcast. Today's chat is all about optimal baby positioning. I chat with the lovely Lauretta, who is a midwife, mum of 2 girls. She's a birth educator, and Lauretta discusses, as I mentioned, optimal baby positioning and how she doesn't believe that there is one ideal position for babies. And in this session today, I drill her a little bit. I ask about evidence. Does it actually matter if the baby's in the, air quotes, wrong position? How likely is it that baby's going to move position? So we talk about common, worries that pregnant women might have. Lauretta then goes on to discuss some really practical tips for during pregnancy and birth prep. And then Lauretta goes on to discuss support for labour and what women and their birth partners can do during labour if the baby isn't in the ideal position, and how to stay calm and confident no matter the scenario. So I really do think if you're pregnant, you're going to get a lot out of this episode today. And I think we just need to dive straight in. So brilliant chat. Before I do dive into this, I do just want to let you know I have a free birth prep class where, as a pelvic floor physio, I talk you through how to prepare your body and pelvic floor for birth. And I think this would really complement this discussion today with Lauretta. I will also share the links in the show notes for how to connect with Lauretta if you'd like to learn more about her and her services. Right. Without further ado, let's dive into today's episode. Lauretta, thank you so much for joining me on the Pregnancy, Birth and Recovery podcast. I'm really excited to chat. This is always a really fun topic. We're optimizing positioning for birth, by optimizing baby positioning. We're talking about birth prep. It's one of those topics, and look, I guess that's the first question. Let's dive straight into it. We all talk about optimal baby positioning. Is there actually any research evidence to show it helps, or is this just, circumstantial evidence sort of thing?
Yes, thank you so much for having me, Kath. It's lovely to be chatting with you. So it's a big topic, and I think sometimes there can be a lot of fear around, is my baby posterior? Where is my baby sitting? And I think we definitely don't have enough research around this area. We know that the majority of babies, so I think it's around 60 to 70% of babies will start their labour on mum's left side in what we call LOT. So basically on the left side of mum's pelvis facing directly out to her side. But it's an interesting one because for some babies, maybe that is a great position to start labour. But then for others, and this will of course depend on the shape of mum's pelvis, the shape of her uterus, what her pelvic muscles, ligaments, fascia, all those soft tissues are doing as well. If there's tension on one side or perhaps in the pelvic floor. So I really don't believe that there is one ideal position for babies to start labour, but obviously a head down baby is ideal. And I think flexion of baby's head is really important. So ideally, we want baby's chin to be nicely tucked into their chest rather than looking kind of upwards, which is what we call deflexed, because we know that then the smallest diameter of baby's head is going to present into and move through the pelvis first. So that's ideal if we can start labor like that. But in saying that, especially women who have had more than one baby, sometimes it won't be until contractions actually start that that chin will tuck and that baby will move further into the pelvis. And I think if we say, oh, there's one ideal position, it kind of oversimplifies the whole process between, mums, women, birthing people, and babies, because we know babies are very good at finding space and they're very good at navigating the pelvis. So I don't believe that there necessarily is one. And we know that even if babies do, say, perhaps start labor in a posterior position where they're facing towards mum's back, most of the time they will rotate. Yes, they might need longer than, the timelines that women are often put up against in the system. And maybe labor might look different and have different challenges, but the majority will actually rotate anyway.
Okay, I've got 2 questions on that, and I want to ask them both together because I know I'm going to forget one. Do you know what, and I know percentages is always hard, but do you know what, you say a large number is going to change position during labour. Do you have any facts and figures around that? And the second question before I forget it is, even having this conversation about optimal baby positioning, is it creating more anxiety and we don't need to be having this conversation?
Yeah, I definitely think it does, and I think it's a real balance because obviously, I'm very much come from the perspective that being proactive during pregnancy is so crucial. And we want to be working on the mobility of the pelvis, the soft tissues, the pelvic floor, your breathing, all of those things to make sure that we're optimizing the space available, we're reducing tension to allow our babies to make those movements through the pelvis. But I do find, and I've found this myself, um, quite like over the years and more recently, that even if I do a palp of someone's tummy and baby, and if I do think that they are posterior, I would never lie to someone, but I do feel a sense of, oh, I know if I tell her I think baby's posterior, that most women will associate that with, oh no, there's something wrong. But it's not true because, as I always say to them and preface it with, it is a variation, not necessarily a complication.
Mm-hmm.
And maybe that is a great position for their baby. If only we could see
And
on the
what
inside.
degree of babies change position during labour?
I don't, in terms of starting labour in a posterior position, I don't know off the top of my head.
Yeah.
And, I've cared for some women who, yes, they have a posterior baby, and there's lots of signs that as midwives we might go, oh, that's telling me perhaps this baby is posterior. So things like irregular contractions, even in active labour, back pain outweighing the pain at the front of the contraction. Sometimes these women will also have an early urge to push before the cervix is fully dilated. And also just things like when we do a palpation, there's things that we can sort of go, oh, yep, that maybe baby is posterior. But I don't know off the top of my head. But I know when I have looked at the research, it does say that the majority will still rotate, even if they begin labour in a posterior position.
Okay.
Yes.
We just need more
Sorry.
research, don't we?
We really do. I think
feel
it's a
the
tricky
same.
one because, like doing ultrasounds on a woman in labour, if we're wanting her to be able to move freely and as she wants to, then doing ultrasounds can be really tricky. So
I feel like it's potentially a similar conversation to what we have had about diastasis rectus abdominis, the DRAM and the tummy muscle separation. A few years ago, it's something that we always assessed postpartum. It's something I guess in hindsight, now that we've got the benefit of research, we were pathologizing it. And a lot of women that had a DRAM within normal limits, we thought it was something we needed to treat and help support women. But now we've got better evidence and research, and we know that the vast majority of women with a DRAM, and if it's less than a few centimeters, you're absolutely normal. There's not going to be any issues with long-term healing. Let's just get you strong again. So we over-pathologized unwittingly. And luckily, research evolves and we're able to say, yeah, this is normal. It's not an issue. And I'm wondering, and I'm hoping this might come about with all this optimal baby positioning talk. What's your thoughts on that?
Yeah, I totally agree, Kath. That's such a good analogy too. And so often we see that during pregnancy and in birth in particular, we pathologize things that are often variations as opposed to complications. And that might be, again, with a posterior baby, like I said, maybe we'll need longer because if the baby's starting towards mum's back, especially if they're starting on the right side, it's going to take longer for that baby to come around to the left if that's the best way for them. And often with posterior positions, again, this isn't to scare people, but just to kind of explain, if their little head is a little bit deflexed, so they're looking up instead of tucking their chin in, that creates uneven pressure on the cervix, which then gives us those irregular contractions or coupling of contractions. So it does mean that they need a longer time frame. If all is well with mum and bub, often they just need time. They need a midwife who can hopefully help them with some great positioning and mobility options if they want to try it. But often it's just more time, and it's such a good reminder for us that so many times we're pathologizing things that are not problems if all is well. But when we make them a problem unnecessarily, and then, sorry, Kath, I just wanted to say, I think what happens is women think their baby's posterior, so then that creates fear, and then in turn, that creates tension in the body. So it makes it's a bit of a cascade, I suppose, in a lot of ways.
And that's why I did have a couple of thoughts whether or not to do this podcast episode. I did one years and years ago, and it was one of the most popular podcast episodes, and I thought it was time to update that. And I would love to get into some strategies for women, like practical strategies to help with baby position. But I do want to preface it by saying I was having a conversation, I won't name the obstetrician, but an obstetrician recently, and they said that optimal baby positioning is generally not accepted in OB circles, and they call it fetal behavior, and they just don't believe there's much that a mum can do about it, and it sets up a sense of failure, like exactly what you just said, Lauretta. So I think listening to this podcast today, I'm so excited to talk about, optimal baby positioning and potentially some things that mums can do, but knowing that, on the flip side, let's not get worried about it, and it might change and think, what?
And that's so interesting because I think also if we think about our obstetricians and where their area of expertise is, it's within that medicalized field of obstetrics and birth. And so I think that, it's nice to be open-minded and respectful of people who are body workers and work with the body and the soft tissues, because we know that these things are so impactful. It would be like going, okay, I'm going to train for a marathon, but I'm not going to do anything. I'm only going to prepare my mind. I'm not going to prepare my body. That just wouldn't make sense, would it? Like you wouldn't turn up to a marathon without going, maybe I'll see my physio, my osteo, my chiro, or my remedial massage therapist. And yes, maybe we don't have the research as such, but we have so much anecdotal evidence from people like myself and people like Fiona Hallinan who have done this work for years in this space, and we see the impact that it has for women, and women will see that impact too. So
Absolutely. I think it's an argument for both ways, and really until the end of the day, until we get more research. So hopefully maybe that's what you can start to do, Lauretta. You can fit in a bit of research, right?
Well, sure. I mean, it's in my spare time.
Because I love research, and I'm not saying if there's no research, like obviously there's so much we don't have research for, and it's not to say it's not effective, But hopefully it's something in the next few years, especially if more women are doing this and spending money on it and
Yes.
spending time, and it's potentially causing anxiety. Like, we want to make sure it's effective. So anyone listening out
Yeah.
here that wants a research idea, here you go.
Please do that. And I totally agree. And I do believe, obviously evidence is important, but I think also sometimes we place so much emphasis on we need the numbers, we need the data. But really, if you break it down, it's really hard to do a randomized controlled trial on something like body work or, positioning in labor because there's so many variables.
Yeah.
So
But there's
it's
ways,
it's a
around it though.
tricky one.
Yeah.
Yeah.
Let's dive into the topic then, Loretta. Sorry, I just feel like I've thrown you under a bus, but not really.
No, that's okay. That's
I
okay.
lovingly threw you under a bus because I love what we're talking about and I love this topic.
That's okay.
Okay.
So the practical tips, was it, during pregnancy?
What are some practical, someone's listening today, they perhaps have been told their baby's, posterior, they're approaching, I guess at which stage first question, at what stage should women start to think, okay, maybe I need to do a little bit to help the situation here?
I really believe that it's, we want to start these things from around 20 weeks. So in terms of just thinking about what our focus should be. So around, supporting mobility in the pelvis. And we want, especially as we get closer towards the end of our pregnancy, so from 36, 37 weeks, obviously being strong is important, but I think once we get to that point, we also want to focus on softening and suppleness of the tissues. So some ways we might do that would be, really thinking about how we're breathing, how we spend our day, obviously we breathe a lot of times during the day. So thinking about, are we doing that nice 360-degree kind of breathing? Do we know how to connect to our pelvic floor? Do we know how to recognize if there's tension, if we're holding on? Do we have lots of tension in our glutes? So I suppose the breathing and body awareness is a really important part, which I'm sure you cover lots for your lovely clients, Kath.
Yep.
And the other part would be, so there's a couple of parts to this. So as I mentioned, so body work. So what kind of body work works for you and your body? Do you see, I love osteos because they have a beautiful whole body, holistic approach, and love, fascia. We know fascia is also really important for our body in general, but especially when it comes to labor and birth. Or your physio, of course, or your remedial massage therapist who specializes in pregnancy. So I think tuning in and listening to your body, if it's telling you that there is tension, if there is pain, and doing something about it, because you don't just have to put up with that and live with it. There's so much you can do to support that. In my classes, I do teach specific daily stretches for people to do from sort of 32, 33 weeks that help support those pelvic soft tissues. And the other one is, as I shared earlier, would be internal pelvic release work. So helping to prepare the internal soft tissues and those little muscles and ligaments that attach to the pelvis to try and make sure that there's, not too much tension internally so that baby can make those movements through the pelvis nice and smoothly, and we're supporting lots of space and hopefully reducing tension.
And we had a chat off air like this. I've never heard of, I guess, anyone other than a pelvic floor physio doing this sort of work before. So we've had a big
Yeah.
chat about it.
Yeah.
Pelvic muscle release inside the pelvis is something we would do for women with overactive, like if we've assessed
Yes.
and identified overactive pelvic floor. Is this something you're saying you do prophylactically for anyone?
Yes. Yeah, but it's more than the pelvic floor. So we work through sort of the back wall of the vagina. So very different to, having a vaginal exam and checking your cervix. We don't go near your cervix. We focus on the attachments to the pelvis. So we work through like the front of the pelvis and around to the back. So if we think about how the sacrum moves during birth, we know that most of that movement and space creation happens at the back of the pelvis. So your tailbone, ideally, if we're not lying on our back or on a hard surface, if we are supporting and using positions that allow your pelvis to get bigger, then the sacrum actually shifts back during birth. So we've got all of these incredible stabilizing muscles, ligaments between the tailbone and the rest of the pelvis. So, for example, we work through the back of the pelvis to try and support release and flow and drainage in those tissues so that they can move optimally during labor and birth. And a big part of what we do is also supporting that connection between women and their pelvis. And so often I'll have women say, "Oh, wow, I didn't realize it was so spacious and so big," because I think we have this, often we're quite disconnected from that part of our body, and we think that the vagina is just a tube, but it's only limited by, the movement of those bony structures and the soft tissues that help them attach and connect.
Is this a vaginal, oh, you don't call it an examination, do you? Vaginal
No.
treatment when you say internal?
Yeah, so we do both external and internal.
And is it in supine, like lying on the back, or do you get women in a different
Yeah.
position?
Yeah, it depends. It depends what we're working on. But usually on their back, like if they're pregnant, we'll make sure they're supported to be tilted to the side. Some, depending on what we're doing, we can do side lying. Yeah, just wherever they're most comfortable, I suppose. But generally on their back.
And
Yeah.
and I'm sorry, we need to have this conversation off air. I'm absolutely fascinated. So you feel through the vagina, you can reach those ligamentous
Yes.
structures around the
Yeah.
sacrum.
Yeah. It doesn't mean that we can always feel them exactly, but I've definitely felt, yeah. So those, like the sacrospinous that attach from, and the sacrotuberous that attach more towards the bottom between sit bone and sacrum, you can sometimes feel them.
So it's like
Yeah.
trigger point work, because that's usually on
Yeah.
muscular structures.
It's not trigger point work, but it's myofascial release basically internally.
But
Yeah.
then if it's a
Yeah. And
ligamentous, it's not going to be myofascial because
no. So we hold. What we do is we gently hold and we wait for the tissues to soften or to talk. Yeah. So it's not, I can see how it's tricky as a physio because, we're not, like I said earlier, our job is not, and our scope is not diagnosis, but we still have a big knowledge base in anatomy and what we're doing specifically, but we're not there to diagnose, a prolapse or to diagnose, other pathologies. But what we do is we provide care. I suppose that's what we're doing, and we're helping women again connect with that part of their body, but also help those tissues, feces, to sigh or to talk to each other and connect. And the other thing is that we also talk a lot about education. So, what people can be doing for their own homework and body work, and also preparing the perineum as well.
okay. So let's you've mentioned quite a few things. Let's just break this down. If someone's about 20 weeks, whether or not their baby's in the right position, might be when we start to get in touch with our breathing, get some beautiful diaphragmatic breaths happening, connect to the pelvic floor, understand if they're engaging, relaxing, if there's any tension in our glutes. You've talked about the body awareness and some stretches, and as you mentioned, education about perineal massage, which would happen later in the third trimester. Are there any other like practical day-to-day things that women could do to help support baby positioning?
I think those would be the main ones because, again, back to that piece of, not wanting to create anxiety. I see a lot of women are really scared to relax or recline on the couch because they think that, oh, if I lie back and relax, then my baby will be posterior. But I don't necessarily believe that to be true. I think, ideally we want to make sure that we are in alignment when we're sitting. So supported by pillows so that our spine is not, we're not going into that banana back shape. but also remembering that, our nervous system has a big piece to play when it comes to pregnancy, labor, and birth. And so, if we're feeling stressed and we need to rest and relax, that is really important as well as a balance between being aware, but trying not to create stress by being so vigilant that we're not letting ourselves rest and relax when we need to.
How about, are there any simple postures you recommend that don't, I guess, create that stress that you just talked about? For example, instead of reclining on the couch, like sitting on a fit ball or,
Yeah, you definitely can. Yeah. I think instead of sitting for hours, lying back on the couch, or even things like side lying, just really trying to avoid that banana back position for long periods. And, I think too, just if we're sitting on the gym ball and just making sure it's the right height for us, ideally, before we go into labor, we don't want, and this would be more from like 37 weeks plus, but we want to make sure that our knees are sitting below our hips rather than creating that squat position, because we know we want that inlet part of the pelvis or the top to be nice and open, to support baby moving into that part. But yeah, I think that would be the main ones really, just wherever you're comfy. I don't like to be too prescriptive about that because, like I said, I think it can create more stress.
how about 4-point kneeling? What's your thoughts on that?
Yeah, absolutely. If you want to lean over the ball and watch TV, I think that can be really great too. Yeah. Yep.
Yeah, right. Um, so you've mentioned from 20 weeks to get started with all this. It's very early in the piece when we don't yet know what position our baby's going to be in anyway. Would you suggest this for women whose baby's in a fine position? Or is this mostly something you'd recommend to women who they know their baby's perhaps in a posterior or transverse position?
Yeah. I think from 20 weeks is just good to start that awareness piece. And then in terms of, the stretches and things that I talk about in my classes, then, any time from like early 30, 33, 34 weeks, if they can, then that can be a really good time to start doing those stretches more daily. So as in like a more routine practice and being really proactive and making sure they're getting the body work and tuning into any pain or tension that they might be having.
Yeah. What stretches do you recommend?
So I teach a side lying release, which is probably more for pelvic floor, hip flexors, and a front body stretch, which is more for the psoas, round ligaments. And then I love a bit of a jiggle as well. So a jiggle over the lower back and the glutes, for partners to do. And depending on what's going on with baby, we might talk about a forward leaning inversion, but again, that might not be appropriate for everyone because there are some contraindications to that too. So it's kind of an individual, case by case kind of thing, I'd
Yeah.
say. Yeah.
Um, and it's really interesting because you mentioned the forward leaning inversion, but not for everyone. But the 4-point kneeling work without inversion.
Not in the same way. No, but you could do I like to teach a bit of the jiggle. So that's for glutes, lower back, hips, pelvic floor. That can be a really nice one just to let go of any tension and also help people kind of tune into that pelvic floor too and let it go. That gentle movement is a really nice fascial
Yeah.
release as well.
Yeah, I love like the lateral pelvic tilts, anterior,
Yeah.
posterior pelvic tilts. Is that what you
Yeah.
mean by jiggle?
Yeah, no, it's called we call it the jiggle, but it's where so you might have your partner or your support person that you can use material or you can just use hands. So you can place a material over the lower back and the glutes, kind of hammock the glutes, and then you hold either side and you're just doing a gentle jiggle movement, and it's helping to soften the fascia, and let everything go. And it's a beautiful one for labor as well.
Yeah, right.
Yeah.
Yeah, lovely. Amazing. What else, Loretta? What have we missed? What have I missed asking you?
um, Well, just more specifically for labour, Kath,
Yes,
did you want to?
exactly.
Yeah.
That's exactly. I just
Yes.
went like, I forgot to ask about during labour.
Yes. So, as I mentioned earlier, we know that there are many benefits to using what we call active birth positions. Now, some people might think that that means that they have to be moving the whole time they're in labor, but that is definitely not the case because, especially in early labor, we know that there'll be times where rest is really important. And you might not feel you need to move with contractions. But as labor progresses, and we move into that active, more intense, working hard part of your labor, often movement can be really helpful for a number of reasons. So, I'll first explain what I mean by active birth positions. Now, we know that the pelvis has an enormous capacity to get bigger, and your baby works beautifully with you by trying to allow the smallest part of their head to come through the pelvis first. They've got little skull bones that are not fused, which overlap and allow that reduced diameter also. So, what I mean by active birth positions is it's really any position that is not restricting the movement of the pelvis to open. So, that means that it can get bigger in the outlet and at the inlet at the top and the mid pelvis and the outlet because the way our sacrum or our tailbone shifts backwards as well. So, active birth positions would be any position where we're not lying flat on our back or on a hard surface that is restricting that movement. So, you could be doing an active birth position while you're lying on your side because even side lying, the sacrum can move. And even if, say, you were to have an epidural, you can still be using active birth positions by going side to side, using a peanut ball between your legs, using a ball on the bed. There's still plenty of options, even if you are restricted to the bed or perhaps you're resting. So, we know that the benefits in terms of what the research says of using active birth positions and working with gravity are, reduced length of labor, reduced need for pain relief. It's better for baby because when we're flat on our back, that changes the circulation to baby. And also, probably most importantly, is that increases the it's women find that they're more satisfied with the birth experience when they're able to be active and move freely, which makes a lot of sense. So, plenty of benefits for that. And I always also think sometimes we can say that and people are like, well, how do I actually do that? So, I like to think about it as setting up your labor movement stations. So, perhaps if maybe you're at home thinking about where are you going to labor? Where are going to be your comfortable spots to move between when you're maybe in early labor? And then if you are moving to hospital, when you move to that birth room, how can you set it up so it looks really inviting for you to move between different stations? So, often the bed is in the middle of the room. So it's kind of like this magnet that draws everyone to it. But it doesn't mean you have to lie on it. Obviously, there might be times where your midwife or your doctor might request that you do to have your monitoring put on, have a vaginal exam, whatever it might be. But you don't have to stay there. And we like to talk about it as, the bed is for leaning on, not lying on so much. So you can use the mechanics of the bed to go up or down. If you're on the bed, you can tilt up the back of the bed. You can get your gym ball out, the yoga mats, and maybe just set up something within your kind of line of sight because I find if women see them, they're more likely to move to them because as you probably know, Kath, when you're in labor and you're in pain, you can go into that tense fight or flight mode. I don't want to move. I want the pain to go away. So I'm just going to stay really still and not breathe and hold everything. And we know that like movement can also be really helpful in working with pain. So if we can keep things mobile and soft and move with contractions, it also gives the pain somewhere to go. So that's the other thing. So active birth positions, set up your labor playground and moving with contractions ideally so that we're making the most of that force of contraction, bringing baby down and also changing the orientation of the pelvis. Or if we're adding really big movements to full range of motion, that's actually pulling the leg bones are pulling the pelvis open and increasing the diameter. So different movements do different things. But I will say moving instinctively is key, because if we can tune into what our body is telling us, women and babies are so clever, and you'll often be doing the movements that you need anyway. So I don't want people to think, oh, I have to do this specific type of movement. Always go with what feels best instinctively. Yeah, and I think all of those things can, give you a bit of sense of
Yeah.
control and something to do with
Yeah.
that pain.
And with that, on that note, when women do need to get monitored perhaps, or they, as you said, they had the epidural, you mentioned sideline with the peanut ball.
Yes.
Is that for both the monitoring and the epidural?
Yeah, it can be both. If you're and with the monitoring, remember that we usually have the option of the cordless CTG monitoring if you are having continuous monitoring. So you can always request that. And yeah, I think like your peanut ball is amazing if you're side lying, put it between your legs, change the positions of your legs. And again, depending on where baby is in the pelvis, we obviously won't go into all of that, but we can make space in different parts of the pelvis too. So whether you're resting or you've got the epidural, peanut balls are amazing for so many reasons to help make sure that pelvis is nice and open even when you're resting.
And I know you just said you won't go into it, but did you mean moving the legs into different positions slightly, like more hip flexion versus less?
Exactly. Yeah. So depending on your leg position, that's going to change the space available in the pelvis. But I think that is really helpful to know, and something I do teach in my classes, because in terms of troubleshooting. So say if, things aren't progressing the way we'd hoped, or baby is posterior, or for whatever reason, then we can troubleshoot and go, okay, well, baby's in mid pelvis. These are some positions we can do to try and make plenty of space in that part. Yeah.
And generally, is it the further the baby descends through the pelvis, you optimally would like your knees apart, feet together, that sort of position? Or opposite, knees together, feet apart?
No, yes.
I always get confused.
Yeah, it's the opposite to what you think, because we see in the movies women pushing with their legs in stirrups and knees apart. Yes, so if we're thinking about the outlet pelvis, you're pushing, we're thinking more, so knees higher, it could be higher than hips, but ideally internal rotation, so knees together, feet apart. Again, if that feels good for you, it's always about that more than a prescriptive kind of position.
The way I work that out, because I always forget, I don't know what's wrong with my brain, but I stand up, I put my
Yes.
fingers on my ischial tuberosities, they're both,
Yes.
and then I internally
Yes.
rotate my hips, and then externally. I'm like, oh my
Yes.
God, the pelvis gets so much bigger. It's a really
It's
cool little party trick.
I think that's so good, and I love to do that in my classes too, because it's the opposite to what people think. Because, and people will say, oh, but my knees are close. How is my baby going to come out? But it's the back of the pelvis that we need that space. And when we do that internal rotation, the back opens up, and the outlet.
Yeah.
The baby
And how would you use a peanut ball if you do want your knees together, feet apart?
Yeah, so you just pop it. So if you're side lying, you'd pop it between your ankles, so knees together, and then pop the peanut ball in between your ankles.
Okay.
Yeah. Or you can just use pillows too to do that. You don't have to have a peanut ball. Towels, cushions, whatever.
Yeah, that makes sense.
Yeah.
Amazing. Loretta, I think we've covered. I really wanted to chat like pre-birth, during pregnancy. I wanted to chat the during birth strategies, which you've just done. Is there anything else to finish off with? What about any things that the partners can do, or the birth support people?
Yes, I think that's a big one. And I think when they have the knowledge about, when they've done their birth preparation as partners, they can feel more confident to support, the birthing person with whatever she needs in terms of movement, in terms of troubleshooting, and encouraging that active labor, active birth positions. So I think partners have a big role to play, and even things like we talked about setting up the space. again, a really big thing that partners can do. I always think it's kind of one of their main roles, as well as being right there and present with their partner, is setting up that space to support active birth positions as well. That's a really great thing for them to do.
Yeah, amazing. So if someone is birthing a posterior baby, any specific
Mm.
tips for them?
Yes. So again, this would depend on what is happening for that woman, but I think in like generally, often what we do see is that that contraction pain is often stronger in the back than it is in the front. Okay, so birthing a posterior baby, like I said, if it is really intense in terms of that back pain, which can be really challenging for women to manage, I would be thinking, okay, what can we be doing to try and support baby's rotation away from mum's spine? So that's where things like your forward leaning inversions or even just that extended puppy pose with a jiggle that I mentioned earlier, again, doesn't have to be material, could be partner's hands on the lower, like on the glutes or lower back during contractions to see if that changes things. So I would do a few in a row, see if it changes the way that they're feeling, and then try something else. So again, the stretches can be really helpful if we're trying to make more space at the front. So you could do a round of the side lying release, the psoas release, and again, see if that changes. There's also some really beautiful acupressure points. So bladder 32, which is it's about 3 finger widths above butt crack and a thumb width either side of the spine. So using thumbs or knuckles into that point can be really helpful for managing pain. The other thing for posterior labors that can be so good is so obviously warmth, the bath, trying to, I would say, rather than all fours, trying positions like extended puppy that are more like an A frame shape, because A frame is going to make more space at the front than a 90-degree angle, if that makes sense. So, and sorry, the other thing was sterile water injections. So it's a little injection under the skin in four little points, usually done by 2 midwives at the same time during a contraction. And it's like a little intradermal injection. So it just goes under the skin. It is water, like its name, and they sting like crazy. They feel like a really strong bee sting when they're going in. But what they do, they kind of work on that gate control theory of pain, that the brain can only take in a certain amount of painful stimulation. And they work usually within 30 seconds. So great for back or hip pain. And there's really, in terms of side effects other than pain and being mindful not to put warmth on straight after, there's really no side effects for mum or baby, but they work beautifully and they can last for a couple of hours.
Okay. And what happens if you're having a posterior baby and you've tried all the things and then you're up to
Mm,
the active pushing phase?
yeah.
Any further suggestions?
I would just be thinking about if baby has stayed that way, well, maybe that's to do with the shape of your pelvis or whatever's going on in terms of tension. And, some babies will be born directly OP, very small number. I've probably only seen maybe 2 as a midwife directly posterior, but, some women they can still birth them, but it does just mean it can be more challenging. So I'd be thinking, how can I support maximum space in the outlet of the pelvis, like we talked about? So, that internal rotation, knees higher than hips or, all fours. How can we allow that sacrum to get huge? How can we allow the pelvis to get huge? And yeah, I think that would be, the main ones for that.
Yeah.
Mm.
Are they more likely to need instrumental deliveries?
Yeah, I would say so. Yeah, it's just because you've got that increased diameter of baby's head, so that head is flexed instead of nicely tucked. Yeah, so it just means instead of baby facing towards mum's bottom, they come out face to pubes, basically facing up.
So
Yeah.
that might be when you get the choice of either a vacuum or forceps or emergency cesarean.
Potentially, yes. But if it's, again, it would depend on the obstetrician and what they're, And the woman's preference, of course, too.
And what about transverse position? I guess what I'm trying to ask is, would many women attempt to have labour if their baby has been in a transverse position for a while?
So again, this would be, so you mean in pregnancy babies like breech or transverse?
Yes. Yeah.
Yes. Yep. So lying across
Lying
instead of,
sideways. Yeah.
yep. So instead of head in the pelvis.
Yeah.
I would say, so it would usually not be recommended just in terms of safety, because if baby's head isn't sitting in the pelvis, then there's a chance that you could have a cord prolapse. So the cord could come down before baby's head, in front of baby's head, or, there might be a leg or an arm or something. But it's, I suppose the one to think about would be, often if you've had a baby before, the uterus is a slightly different shape. There's more space, there's more laxity. So often during pregnancy, babies can be more likely to be breech or transverse. And that, the other thing is that they might not necessarily engage before labor. So by that, we mean the widest diameter of baby's head isn't sitting in the pelvis before labor. And that's not necessarily a problem as long as it's sitting just above the inlet, because hopefully once those contractions start, they might just need contractions for baby's head to get in the pelvis. But a high head is different to a transverse position. So yeah, two, I suppose, quite different things. But I think often women can think, oh, that, baby's head's not engaged yet. But like I said, it's not always a problem necessarily. Sometimes it might just need contractions. Yeah. But in terms of sorry, Kath, I was going to say in terms of percentages, when we look at from 37 weeks, the percentage of babies who would still be breech, for example, it's very small. It's like 3 to 4%. So, yeah.
Amazing. To finish off with, any final words? Let's say there's a mum listening today who's feeling a bit anxious about it all and a bit worried, and they might be later in their stage of third trimester. What would you say to that mum?
I think, definitely try and do the work in pregnancy to support your baby and your body, and also just your comfort levels, but also trust that, our babies are very good at finding space. And when we, allow things, and we can, I suppose when we go into it with a mindset of, yes, it might be hard, but I can still do this, and from a place of trust rather than fear, I think that can be really helpful for women too, rather than getting bogged down in, oh no, my baby's in the wrong position. It's like, no, that's just a variation rather than a complication.
Amazing. Thank you so much, Lauretta. How can women come and find you?
Yeah, so I'm usually on Instagram at midwife Lauretta, and my website is also midwifeloretta.com.au.
And I'll link all those notes in the show notes too. Thank you so much for your time today, Lauretta. I thought your daughter would come, but she didn't.
Done
it's been
so
silent
well.
for a whole
She's got
hour.
the puppies out. I know, she's done a great job.
Amazing. Thank you so much coming on today. I really appreciate your time. Fascinating conversation. Sorry I grilled you a little bit at the start, but I loved it.
Hey. It's okay. I'm here for it.
Thanks, Lauretta. Catch you soon.
Thank you.
Thanks for listening to the Pregnancy, Birth and Recovery podcast, brought to you by Fitness Mama, your app for home-based, physio-led pregnancy and postnatal workouts. If you found this episode helpful, please tap follow, leave a quick review, and share it to your stories. Tag at kathbaquie.physio. I'd love to connect and cheer you on. And don't forget to check out the free trial at fitnessmama.com/free to start feeling confident, strong, and supported today. Until next time, remember, a strong body, a confident birth, and empowered recovery is something you deserve. This podcast is for informational purposes only and is not a substitute for individual medical advice, diagnosis, or treatment. Please consult your healthcare provider for your personalised guidance.